We are joined now by Dr. Gary Lichtenstein to talk about AGA's symposium. It's titled Advent of Biosimilar Products in U.S. GI Practice. So talk to us about the current U.S. regulatory pathway for biosimilars.
Well, first thing is important to define what is a biosimilar, and that's an agent that is made to simulate what an originator biologic is. And in an effort to do so, the first thing that's done to evaluate that is the molecule is broken down and looked at the amino acid structure, and it's reproduced. The purity, the chemical structure, and that then is something that then is mimicked, if you would. But the tertiary structure is not easy to mimic. So in an effort to look at that, the first thing that's done is to look at the chemical structure when trying to gain regulatory approval as a pathway. The subsequent thing that's done is to look at the pharmacokinetics, immunogenicity, and all other aspects that are deemed to be considerably appropriate. It's the totality of the evidence that is the clinical and appropriate aspect that's looked at when the regulators say this is something that should gain approval.
So what's the evidence currently available on biosimilars for treatment of GI disorders?
Well, we have two agents that have come to their patent time, infliximab and adalimumab. These agents have now undergone processes to evaluate their chemical structure, and there's now at least 20 different formulations in development at this point in time. They're made in different companies, different countries, with the intention of bringing these to the market in the United States and throughout the world. And this is something that has occurred outside the United States, United Kingdom, France, the EU. Other places have done so before the United States.
So they're prevalent or becoming more prevalent overseas?
Yes, and we're learning more about them, if you would. Since they've come to market, there are studies that have been done to see if they are similar to the originator. The issue that always is of concern is there a difference in the structure of these molecules, a tertiary structure? Is there afucosation that can lead to an immunogenicity that was unrecognized? So tests are being done in the best subjects we can, the human being, if you would, in an effort to define that.
So then how would you recommend that clinicians talk to their patients about the use of biosimilars to treat their symptoms or their issues?
Well, they've gone through a rather extensive process through the Food and Drug Administration and the regulators in the EU. So they're very similar when it comes to the amino acid structure. When it comes to the tertiary structure, there may be slight differences directly. These are agents, the intent of these being to lower the cost of care. If we look in general, some of the statistics that are important to recognize, the biologics account for approximately 1% of all of the drugs used, but they account for nearly a quarter of the cost of the drugs that are used directly. And with use of this, the estimations for the EU and the United States are that there can be significant cost savings. And those cost savings can be in the billions, hundreds of billions of dollars annually. So these are things that are similar to the generics, if you would, that we have. So someone takes, for example, azathioprine, they may not have the brand name, but it is a biosimilar. And they're somewhat similar to that, though they're different structurally because these are larger molecules with different structures. So the totality of the evidence looks at safety as well, and it's perceived to be safe for patients.
So even though right now they're much harder to develop, they expect them to lower the cost for healthcare.
That's the intent. And in the EU, for example, they vary. If you look at the United Kingdom, it's about a 30% cost saving. If you look in places such as Norway, it's 60-some%, for example, for infliximab. The best estimates are 20-30% in the United States. And the big question is, do those cost savings get passed on to the patients, or is it to the insurance companies, to the health systems, and to the federal government? And at present, it seems most of the benefit will not be directly to the patient.
All right, so we'll have to wait and see, I guess.
I believe so, and they're now available in the United States, so the process of education is absolutely critical. The AGA has developed a committee and a plan to disseminate information and to really educate gastroenterologists as well patients alike to better understand exactly what they are.
All right, Dr. Gary Lichtenstein, thanks for joining us.
Thank you. I appreciate the opportunity.
Sure.